I'm good, good.
Yeah. Good. So to see again.
This one controversial, and I think, well, it's actually not controversial, but it's very topical at the moment, and we obviously are from Melbourne. So one of the things that's coming across in the media and also to the trauma departments nowadays is the attack of the machete.
The machetes.
Yeah, so it seems to be an increasing amount of people who are being injured with machete attacks and so forth. And I thought we could quickly have a chat about the types of injuries associated with it. So talk to me the difference. Obviously, you've got a background in using knives all the time.
Yes, yeah.
Tell me the difference. What sort of, somebody's holding a knife and they attack somebody as opposed to somebody who's holding a machete. What type of difference or what type of injuries, how would they differ between the two, do you think?
Yeah, I think, broadly sort of, they would all fall under the umbrella of penetrating trauma, which is a big topic, important to be aware, and something that we fortunately don't see a lot of here. Like if I asked you, have you seen any stabbing injuries, penetrating injuries, you would think I meant this month or whatever. The American colleagues of ours, they'll think you meant today.
Yes.
Have you seen any stabbing today?
Yes.
So it's very rare. But yes, to the different mechanism, I think a knife would be shorter and sharper as opposed to a machete, which you could do some more slashing type injuries with, couldn't you? So you're probably going to see slightly different issues with the two. But penetrating injuries as a topic, what do you reckon?
See, I like, and I'll just touch on what you said there a moment ago about the stabbing and the laceration. And I can even go back further saying, well, it all depends on what part of the state you're actually working in. Like if you're in Wangaratta, the incidence of stabbings and machete attacks is different to what it can be in metropolitan Melbourne. So depending on where you work will determine how frequently you are exposed to these type of injuries. So knives, to me, people who hold knives tend to stab forward or stab down or stab up, depending on male or female, and there's papers out there determining males hold knives differently to females. So the injuries that you get with those tend to be more of a stab, so a deep penetration type stuff. Whereas a machete attack, obviously it's a long bladed item. People who hold machetes don't use it like a sword and stab into people. When it's used with force. So you get significant lacerations. So we're talking through lots of layers of skin, muscle, tendon, bone even, to the point of amputation can be sometimes. So the actual type of injuries that you may get may be different. So the stabbing type injury is the grabbing a knife, looking at the knife, determining how long the knife is, how far the blood goes up the blade, and all those sorts of things, and the area in which the person has been stabbed. But a injury from machete may be more obvious because it will be a significant laceration with obvious involvement. So I think we need to think about the mechanism for that. And it's not too hard, is it, really? What do you need to do? Like if you come across somebody who's copped a machete on the upper arm up there, what's your management for them?
With any of these penetrating injuries, time is of the essence, isn't it?
Wonderful.
And, rush them to ED, but I'm not going to say them in ED. Most of these people need, if it's to the trunk, they'll need interventional radiology or surgery to fix them. So what's the old adage like? Airway, breathing, circle, diesel. This would be a cohort.
The other D is danger. Like, we can't emphasise this enough. If there's been an assault of that type, make sure your scene is safe before you actually run in, because we all get hyped up. It sounds like a really good job when we drive there really fast. And old school, pull up the handbrake and pull to a stop, which of course is now just pull the little switch. But make sure the scene is safe. Ensure that there's a police on scene and they can confirm that the area is safe. You don't want to be putting yourself in a situation where someone's been attacked and then other members come over with other machetes and they want to take it out on you for trying to help. So danger, check for danger first, So certainly the consideration is we need to move this person to definitive care as quickly as possible. But you can't take them to definitive care if you haven't addressed the issues. So what I would suggest is that you recognise the areas, and if you've got a spurter or something like that, then you need to address it, you need to fix it. There's no point rushing if that person continues to exsanguinate their whole volume while you're there trying to fix it. So attend to it, do what you need to do, and whether that be the application of just firm pressure and bandages, whether you need to upgrade to the use of a quick clot or something like that, or whether you need to actually apply a tourniquet and all the other things as well. So that will come from your experience and the type of injury that the person's got. But the consideration should be quick addressing, first aid of the bleeding, and moving towards definitive destination.
So if we just went through the whole body, let's do it. So if we did limbs first,
Good.
Arms and legs.
Arms and legs.
If they're completely amputated, bang, what do you do?
So there's two things you need to consider there, and that is obviously you've got to consider the management of the stump that you've got left. So whether that actually requires the application of a tourniquet. And injuries like that often, correct me if I'm wrong here, if you get a direct laceration and amputation, you get some vasoconstriction of the vessels, and so the bleeding can sometimes be controlled from that. Other times, obviously, you'll find that it's spurting out. So application of a tourniquet would be appropriate in that person. Dressing the stump and off you go to hospital. Dressing the stump you could probably do on the way, but certainly addressing the bleeding initially from the start would be really high priority, and then dressing the stump as you're driving to hospital would be an appropriate thing to do. The actual limb that's been amputated, so we want to cool them. The ideal temperature from memory is around 4 degrees, thereabouts. We're not wanting to freeze them, but we want to cool them. So into a plastic bag, and then even if you can double bag it and put it inside something that can keep it cool. So we all have plastic bags within the ambulance, and then try and double bag them would be terrific. And then if you've got access to things that can cool it, we don't carry ice machines around on the truck with us, unfortunately. But certainly you've got things within your car. Often people have fridges, and I'm not suggesting you put it into your fridge, but often it's full of cold bottles. So if you've double bagged it, then even if you triple bagged it and poured that water in so that it's not getting onto the limb, it helps reduce the temperature of the limb. So they're the two things you need to consider. So that's for arms. For legs, same sort of thing. Analgesia as well, because I'm tipping it hurts.
Give them some pain relief.
Pain relief.
Good. And
torso, mate. What do we do there? So let's say machete. Oh, not a machete, because unless I go like that, I'm probably not. I'm going to just cut your skin open if I slash down. But knife.
So knife to the chest, and you'd be worried about tension pneumothorax. A pneumothorax which might tension. Now keep in mind that that's not immediate, as soon as there's a stabbing, people get on the phone and response time's pretty good, and that tension pneumothorax.
What service?
Hypothetical in 50 years' time.
No, response times can be very good. They can be slow depending on the workload of the service at that time.
Well, so to that point, if there's been a slow response time or the call was made to triple O sort of time after it happened, this sort of stuff, then you'd want to be really worried about a tension pneumothorax. But I think if you've just turned up a minute after, if they are hypotensive, it's much more likely to be due to bleeding rather than obstructive shock from a tension pneumothorax. What else would you worry about with the stab to the chest? Hemothorax, of course, it can lose a lot of blood there. And then if it gets into the heart, you could nick it. And remember, the heart is wrapped in the pericardium, a potential space, just a few mils of fluid there now that makes it slide smoothly. But it doesn't take much bleeding into that, into the pericardium, and cause a pericardial effusion, which constricts the heart, and you might see the blood pressure start to fall again. Any other thoughts on chest stabs?
I think ultimately the thing that those patients need is they need definitive care. They don't need the back of the ambulance. They need the back of the ambulance to transport them to definitive care. So recognition, minimise scene time, put the person onto the bed and start moving at your earliest opportunity. Consideration for things like IV access, analgesia and all the rest of it. Yes, we want to give them pain relief, but more than anything, this person needs to be in surgery. So that person, non-trapped trauma with penetrating injury to the chest, you are close to hospital, put them onto the bed and start moving. And IV access and analgesia and all those sort of things on way.
En route,
for safety side of things, obviously bring a police member with you in the back of the vehicle, because you don't know how that person's going to respond. More often than not, if you've been stabbed, you're generally pretty compliant and allow things to happen to you. But there's always those patients that can arc up as well. So, but just something to consider, the lacerations are going to be bigger, so machete injuries tend to be, like I said, big wounds as opposed to a knife stab. So something to consider. We're going to
Yeah.
see more of it out there. It's certainly going on at the moment. We've got our amnesty for people to hand in their machetes, but they're still out there, and they probably still will be out there for a while. But think about how you're going to pack the wound, how you're going to manage it, but ultimately get them off to hospital.
Yeah. Good.
Good.
So that's the chest. What about tummy?
Same thing. Same thing. If the guts
Yeah.
are hanging out, put guts back in.
Yeah.
You know, as best as you can. Try and clean things as much as possible. You don't want a heap of dirt and all the rest of it. If it's obvious stuff, I wouldn't
Yeah.
spend time picking out minute things, but obvious debris,
Yeah.
take it off.
Yeah.
Put things on. Wet gauze over the top of the wound.
Yeah.
Transport.
Transport.
Yeah.
Would you put something in the wound? No?
No, so what's the recommendations with regards to filling wounds? It's not really recommended so much.
No.
You know, you talk about somebody who's got intra-abdominal injuries, packing the wound is a massive space,
Yeah.
and you're probably never really going to get to the direct source of where the injury is.
No, that's
So,
that's
transport.
why it's not.
Transport.
Transport.
Yeah,
You
can I
know
say it
it.
anymore, mate?
Yeah, transport. No, it's key. I agree.
Hmm.
So that's abdo, chest. What about neck?
Oh, neck's a nasty one. Transport.
Yeah.
So
Airway?
it's really hard. So yeah. So it's also I've done a really nasty job, a couple of really nasty jobs where people have had injuries to their necks, and I had different approaches to both of them. And one of them went into cardiac arrest and got trismus. So management of that patient became really difficult with a neck sanguinating neck, and trismus, couldn't open the mouth. Then into arrest, maintained trismus. What access could I have? Nothing else but front of neck access. So that was the other time I've done front of neck access on the patient. And that was quite some time ago before the scalpel finger bougie that we use nowadays. So it's a little bit more difficult back then than what it is now. The other one was a patient with a significant injury to their neck and also to their upper airway, and so they were gurgling and bleeding. But I was in a metro region and arrived on the helicopter and drove them to the closest hospital, which is a level 2 trauma centre. So my considerations was this is potentially going to be a very difficult intubation with lots of complications in the back of an ambulance, or to the local hospital 10 minutes down the road with ENT surgeons and anaesthetists and several other physicians there, and I chose to go for that option. I actually got a rap over the knuckles for it, saying that I should have transported to a trauma centre. But that was my decision at the time, and you've got to own your decisions. You know, sometimes you make good decisions, sometimes you make differing decisions to what other people believe. But I'll wear that. That's fine. No dramas. So the thing I want to think about is if you've got a significant injury to the neck and it's bleeding, how do you put pressure on it?
Yeah, it's tricky, isn't it? It's a fair area, and you compress that too much. And you wouldn't be wrapping a tourniquet around the neck.
No, probably not. So a good way is obviously just direct pressure. So gauze, somebody applying it to the neck and holding it in position. The other good way that I've seen is the same sort of thing, but with a padded up gauze to the neck, but underneath the armpit and around there. So it goes that way, up and around, rather than wrapping around the person's neck.
Clever,
go underneath the armpit, and then it can put direct pressure on that side. So it's a good way to hold it in position without somebody being physically over the top and actually holding it to them. It's really hard. So bleeding to the neck, the patient has the significant potential to deteriorate very rapidly if they've nicked a major vessel. And more often than not, with normal response times, they're probably exsanguinated by the point you've actually got there.
There's all these blood vessels going to the head, but the brain weighs 2% of the full body weight, but takes like a quarter of the energy or something. Tons of blood up there. So, pressure. Would you put anything on the gauze? Well, TXA or adrenaline or something? Would you do that?
TXA, and certainly don't know about adrenalines. In the pre-hospital environment, I think it'd be something you'd want to consult with a physician at a hospital to confirm whether that's appropriate. TXA on the gauze, I don't know. Once again, I'd be making a phone call to somebody at a hospital receiving trauma centre to say, I think the ultimate advice would be just start moving.
Exactly.
Continue pressure and start moving, because the person needs to be in a trauma centre, not in the back of an ambulance.
So let me throw this to you. You've mentioned a couple of times movement, transport. Does that mean that it would be better if that was all you got? Because when you turn up as a paramedic, you're pre-hospital provider in the gear, any allergies, any regular medications, let's check your blood pressure, how's the dog, all this stuff. that adds time without any value.
Yep.
So, what's your gut feeling? Because there's evidence on this, you know, transport by ambulance versus other means, be that taxi, private car, police car, whatever. If I said just jump in an Uber, get to the something.
Yep.
What do you reckon?
All depends on where you are.
Yeah.
So if you are in a close proximity to a big hospital, then the benefit would be for, especially, you know, when we look at our guidelines, it talks about, I think it's 10 or 15 minutes, maybe even 20 minutes of a trauma centre with somebody with a penetrating injury. Don't even do CPR, put them on a bed and start driving towards definitive destination. So the idea is this person needs surgery to repair their injuries, not paramedics on the side of the road putting in big cannulas and doing ultrasounds and strapping legs together and all that sort of stuff. They need to be in a trauma centre where they've got a multimodal 360-degree approach to this patient. They can cut them open and fix the vessels that they need to be fixed. Yeah. So you can't say black and white, one or the other though. Yeah. So every case has differing circumstances. You can have a significant penetrating injury and be close proximity to a hospital, but your extrication out of that place may be 15, 20 minutes. So therefore that delays your decision about what you can do there and what you need to do on the way. So there's times when you can do one and there's times when you can't do that same approach. So you have to be flexible in your approach. The main thing that needs to be ticking in the back of your mind is that driving to a definitive destination is the most important thing for a surgical patient. There's lots of other medical patients that you can spend time at, seeing and manage, but that surgical patient, recognise, the big thing, recognition really early. And declare it. I think if you recognise this person's got a surgical emergency, hey guys, this person here has got something that needs surgery. We need to minimise our scene time and be out of here as quickly as possible and on the road. Can you provide hospital notification for me now? Can you provide extrication devices so we can get this person out? I want IV access. I want drugs drawn up. Let's get going. You know, and be clear about what you actually want to do, so that people are all on the same page.
That sounded very assertive, and that's very good. No, that's good. No, I love it. No, I'm saying it as a compliment, and in fact, it is so important that that's part of one of the mnemonics out of a group in UK, sort of on how to manage stabbing injuries.
Yeah, right.
The mnemonic is stab 5, and the A, just what you did there, because people expect stuff to happen. You know. Yeah. They're on scene, the ambulance is there, everything's fine. So, you know, this is the few cases where you got to take the other approach and load and go. And, you know, the culture of tertiary educated paramedics, you know, like it's always stay and play, except for these cases. So being assertive in that regard and saying, we're going. That's important.
I think, you know, recognition, the important thing is to recognise that this is a person that needs hospital, not us staying a plane. There's lots of things I want to do to those patients, and there's lots of procedures I'd like to play out and do, but I have to recognise what needs to be done right now and what needs to be done in the back of the vehicle and what can I forego. And I can guarantee you that if you turn up to a trauma centre with somebody who's got significant injuries and you've put a 20 gauge in the back of the hand on the way to the hospital because that's all that you could get, in the effort to expedite their transport, they would say, job well done. Good on you. They need to be here. We appreciate you transporting them as quickly as possible. So,
but what allergies do they have? What medication? You don't know which type of statin they're on normally.
I guarantee you there will be somebody that will ask those questions, but I think you're well within your rights to go, recognising surgical emergency, I've foregone a lot of stuff to get them here as quickly as possible.
It's good. And, you know, also to this point, the people that tend to be victim of this are young, fit, healthy, so they compensate. So even though they might look good, and people say, surely you got a bit of time to do a few more things or whatever. No, look, they're tachycardic and they've got the mechanism. So the fact that the blood pressure is good, the GCS 15, whatever, it may not be in 2 minutes time. What's the word? Talking then dead, you know?
Talking then dead.
Isn't that what happens? With these they compensate and then drop off the perch.
We should put that in our guidelines somewhere. Talking and dead.
That goes from one to the other. But so with these transport issues, so you got to get them there as quick as possible. And lots of observational studies would suggest that people transported by police do better than people transported by ambulance. Is that just because of the time delay? paramedics do something they shouldn't, and where does what do we do with that information?
Well, it's interesting, isn't it? And I think that's where the Stab 5 came from. Correct me if I'm wrong. Is that the recognition was police would turn up, apply compact tourniquets, put them in a vehicle and drive really quickly.
Yeah.
Whereas we turn up, we apply compact tourniquet, we put dressings on, I put a needle in you. What allergies? What statin did you say you
that's
take?
right.
I'll give you a bit of analgesia. Oh yes, we'll get them onto the bed. No, reposition them on the bed. Load the bed into the stretcher. Signal 1 details, blah, blah, blah. And so our scene times blow out. When in reality, we should be doing what the police do. Obviously, there are some things that we do need to do to intervene, but initial first aid management to stop and control the hemorrhage if you can, but recognise the person has got a significant internal injury with internal hemorrhage, which needs to be fixed in hospital. So we get them there as quickly as possible. And it's strongly suggested in the research that's out there at the moment is that should be our approach for those trauma patients. And so non-trapped trauma, get them moving as quickly as possible.
Every second counts, and I think James Oswald, colleague of ours they got a good podcast, Clinical Conversations.
Yes,
he looked into some of the it's great. You got to listen to that. He looked into some of the literature around this stuff, and there's 1% increase in mortality for every 1 minute delayed in scene time, right?
Yeah.
So
what do you do if it takes you 110 minutes?
Yes, certainly. And so are you. You're out of a job if you take 110 minutes on scene. We're down the road. We're on Punt Road. We're a minute from Alfred, but we delved into the social history. And
That's right.
the reason he got stabbed was actually because this and that person said this. Like, no. So that should be the aim. Scene time less than 100 minutes. Just get going. There won't be any dramas at the receiving facility. No. That's all you've done is you've maybe got a name and
I think declare it as well when you turn up. Go, hey, I haven't done this and I haven't done that because I wanted to get the person here as quickly as possible. And I think that will be met with good job.
We had a stabbing a few months ago up in at work, and there was one of those handovers. The bat phone goes off in ED, and often it's full name, date of birth. We think they might be septic. The temperature's 37.7. They're on the way to sepsis. This was like, we're 5 minutes away. They've been stabbed. See ya. Oh, it was great.
Yes,
it was enough, and we got all ready and prepared, and got the relevant teams there, and got the people out of recess that didn't need to be there, and so. Be succinct and quick and move. Transport.
You've wound me up because one of my big triggers is people going, we're 5 minutes from hospital. Get your hospital ready. And then I can look at cruise time spent with the patient. So arrival at scene, management at scene, and then transport time to hospital. And unless you are in that metropolitan region 5 minutes from hospital, you should have provided a sit rep to the hospital much sooner.
Early,
it seems to be one of those things that we tend to forget a little bit, and we often delay it until we actually start moving towards definitive destination. And then sometimes it is only 5 minutes from hospital, better give them a sit rep now. Now for a hospital, and I know in metropolitan Melbourne at the moment, hospitals are full. And so for the triage nurse and the admitting officer to generate space for a significantly unwell patient within 5 minutes is really hard. So if you've got that opportunity to provide a sit rep from scene, and early hospital notification, that can be to your ambulance supervisors in the control centre, or it can be to the hospital directly to give them a heads up, say, we are at a significant incident and we are going to be bringing a patient to you in the next 15, 20 minutes. We're giving you early notification to start thinking about creating some space. Stab wound to the chest and abdomen, I'll give you more later. Can I have the name? No, you can't. This is an early heads up.
How do you spell that middle name again? So,
it's really something we need to get better at. I think we do it really poorly, and I think we need to improve. I don't know what it's like in other services and other jurisdictions, but it's definitely something that we can do better.
It's almost like whether you sort of given a notification to hospital, even requesting backup if you turn up as ALS, like a windscreen sit rep. That'll be a thing, We're at scene, and this code one short of breath, sitting up, laughing up, offering us a cup of tea, don't worry. Or you know, tripoding at the front of the hospital, sweating.
Yeah.
We'll bring back when we've counted the respirate, you know, whatever.
Yeah.
But you know, so yeah, early sit prep. But this transport thing, like, you know, the research, they've tried to figure out and try to adjust for injury severities and stuff, but I'm not sure they can adequately. There must be. Is it purely because ambulance take longer and doing more things? Is that why people transport by ambulance do worse?
Well, because I don't think police or other first responders that would transport quickly have got anything else to do.
No.
Like they just they attend to a bleeding wound and put them in a vehicle and drive.
Yeah.
So
that's all they do, but is it just the time difference or paramedics doing something iatrogenic? Fluids?
Certainly within our service that I work in, the fluids has been wound back. There still is the use of fluids. If you've got somebody who is hypotensive and tachycardic, there still is a recommendation to give them some fluid. We're not pouring in the 40 mils per kilo up to 60 mils per kilo that we used to do in the past. But certainly if they've got no blood pressure and tachycardic, then give them a bit of fluid and see how they respond. And that may only be 250 mils, but check for a response. And if that brings their blood pressure from 50 to 70, that's moved in the right direction. We don't then want to take it to 140. You know, 70 to 80, maintaining okay, this is good stuff, this is where we want to be. That's our sweet spot. When they start to lose their conscious state, we need to give them a bit more and so forth. So these are the things that we intervene so much. And, you know, where's a good spot for a vein? I can't find one. Oh, can you get me another needle? I've missed with this one. Those sort of things add time.
It does.
It's those small creeps that make our scene times longer and longer. So we need to think about ways at which we can minimise that, and recognition of proximity to hospital and things that I can do in the back of a vehicle versus things that I must do on the side of the road. So my suggestion would be stab, patient on the ground, altered conscious state, pick up onto the bed, literally that quick. Police officer, get in the back with me, give them the details as I go. Can I gather any other history from the people at scene that I need to know immediately? On the bed, and start moving towards definitive destination. Maybe if there's a possibility of another seat in the back, maybe the police officer up the front, you can then start doing your management, which is those IV access and the fluids. When you are set up ready for your IV, pull over, stab, do your IV, secure, move off. Don't do it as you go, because the likelihood is that you're going to bounce, you're going to stab where you don't want to. We want to make sure you get the IV in properly. So you set up, you pull over, you put your needle in, it's 30 seconds, you continue on. So those sort of things. Airway management, if they've got immediate airway threats or airway emergencies, then you need to address those. Obviously, if they're frothing out of their mouth, not breathing well, you need to address those things. Obviously, the doctor's A, B, C, D still applies, but we need to be moving. We need to be going. Get the patient moving towards hospital as quickly as possible.
That's right.
So that's why we're different, is because we've got lots more things in our bags that we want to do, as opposed to somebody that doesn't have the bags. And so they do the simple first aid and start driving, which just improves scene times.
And if they've got one significant stab with a machete or a knife, whatever, and then they got lots of fine abrasion slashes, you'd be tempted to be drawn to that and check the back and the legs, and you know, but none of them are bleeding, they don't need attention. But you could do 3 or 4 things at once, couldn't you?
No,
like,
not me.
I'm
one thing at a time, mate. I can't concentrate more than that.
No, but what I mean is, like, what's happening concurrently is transport, IV, history taking, and you'll be counting the respirate out of your left eye whilst you're doing the IV there and asking what statin they're on. And so
a good word I like to use for people is eupnea. So normal breathing. So you don't recognise normal breathing. So as we sit here and communicate, I'm not looking at your breathing pattern. But if I was sitting here talking to you and you go, I guarantee I'd know that, so I'd probably pay more attention to it. So pay attention to those small things of recognising what's normal in the patient. So if you notice abnormal breathing patterns, you'll pay more attention to it, and we'll write some accurate documents. But yes, concurrently try and do things as you go, gathering the history, looking at the respiratory rate, looking at the odds, inserting the IV cannula and all that sort of stuff. So
perfect.
We're still slower though.
That's That was the solution. So would you suggest they go by police?
No, because if you've got the resources to put them in the back of an ambulance, we can start, we call it out of hospital care immediately. So that when they arrive at the hospital, they've got things started. So hopefully they've got appropriate access. If they've required fluid, if they've required analgesia, have they needed TXA, have they needed dressings and splinting and all those sorts of things. We've started. And so if you've put somebody in the back of a police car for 20 minutes and done nothing, and we all arrived at the same time, we could have started, we won't get there as quickly as the police officers, but we will have started the out-of-hospital care prior to arrival at hospital and maybe address the bleeding as we've started on the way, whereas the police car, this person's still bleeding potentially on the way back. So I think even though our scene times may be a bit longer, we actually do have benefit in that we are addressing some of the emergent things that need to be attended to.
Yeah. Well, do you know how it works with ESTA? You know, if you call 000 and say, you know, well, they ask, do you want police, fire, ambulance? They'll say ambulance.
Yes.
But when the call comes through, you've been stabbed.
Yeah.
What if there's a police car a couple of minutes away? It'll take you 15, 20 minutes to get there.
Yep.
Would ESTA or like 000, would they advise or liaise with police?
I don't think that occurs here in Victoria at this stage. I think more often than not, certainly within Metro Melbourne, depending on the workload, obviously, your ambulance response time is reasonable.
Yeah.
And by the time police have arrived at scene, secured the scene, ensured safety of the scene and not just attend. Because if they just turned up and attended to the patient, they could be out of there really quickly. But they don't. They have to turn up and they have to go, well, where's the offender? Can we do a sweep of the area to make sure that that area is safe before we then attend to the patient? So scene safety is an ultimate thing that they need to do. When the ambulance call comes through, if it comes through as a stabbing, the immediate thing for stabbings is that they will then check to determine if police have actually been activated as well. So that sort of ensures scene safety. And often our dispatchers, they're very good that they will recognise that scene safety is a big concern and they will suggest to ambulance crews, perhaps hold off. We haven't got police or confirmation from the police that the scene is safe. So they're really good in looking out for our ambulance crews as well. So
nice.
Hey, we digressed so much in that conversation. We were just going to have a 5-minute chat about being attacked with a machete, but all of a sudden we're changing the dispatch.
That's what happens. So, good. So penetrating injuries, the management is stab 5, which the sum of that is just be assertive, be quick, get going. And the 5 stands for, no more than 5 minutes, but you'd like to see it less than 5 minutes, surely.
Well, I think logistically less than 5 minutes hard. But 5 minutes would be a good aim for us to have. But, there's many logistics, physically picking up people and putting them onto the beds, depending on the size of your crew that you've got attending, can affect that. So there's multiple variables that will affect your time. But the focus in our head should be minimal time on scene. Person needs to be in surgery. Let's get them going. We can do stuff on the way.
Perfect. And verbalising that to the team to say this is one of the few instances where we don't stay and play. And
that's right.
It's time to load and go. No, I like it.
Good.
Anything more?
No, I think that's covered it.
I think we're at the 5-minute mark.
I think so too, mate. Good on you. Well done. Thanks again, Alex.
See you, mate.